Now let's look at contrast-enhanced ultrasound of scrotal diseases. This is a little different from your normal contrast-enhanced ultrasound examination, for example, of the liver. The transducers used when you're examining the liver are predominantly of the 3, 4 or 5 megahertz level. When you're examining a small part, such as the testes, you're going to use higher frequency probes. The physics of the microbubble does not allow high frequency probes to adequately visualize the microbubbles. You need a higher dose than you would normally use in the liver. Those of you who are familiar with the drug that is predominantly used in Europe, SONOWORLD, will know that for liver lesions you are injecting a dose of 2.4 mils, but for the testes you would need to inject 4.8 mils to get adequate visualization. This is not of concern. The initial dose-finding studies indicated that the appropriate safe dose was 4.8 mils. However, over the last 10 years, the improvement in technology has allowed you to inject smaller and smaller doses for observing lesions in the liver. So 4.8 mils is perfectly safe and adequate for the patient. In the testes, you're only interested in the arterial phase and the early parenchymal phase. Examination for about a minute to a minute and a half is all that is required. Also, be aware that the inflamed scrotal contents are more likely to enhance to a higher degree than the non-inflamed testes. And this takes importance in the presence of epididymitis, abscess formation and infarction. The testes and the epididymis enhance rapidly, but the arrival time varies greatly between individuals. You should take time when performing this examination. The arteries enhance first, followed within seconds by complete parenchymal enhancement. The scrotal wall tends to enhance to a lesser degree than the contents. There is no accumulation of microbubbles in the parenchyma of the testes, and enhancement declines over a very variable period of time, such that there is minimal residual enhancement at 3 minutes. Again, this is very variable in the inflamed testes. Experience is needed when examining the scrotal contents, and the advice would be that you learn to do contrast-enhanced ultrasound at the level of the liver or the kidneys before you attempt to do scrotal contrast-enhanced examinations. Now, there are certain recommendations for the use of contrast-enhanced ultrasound in scrotal diseases, and I am going to demonstrate to you in the next few slides the data that is available and published in the European Federation's guidelines to the use of contrast in scrotal diseases. First of all, let's look at the torsion of the spermatic cord. Contrast-enhanced ultrasound may be used as a problem-solving technique in children with small testes where conventional Doppler imaging methods provide suboptimal assessment of flow. Sensitivity of color Doppler flow diminishes with the size of the testes. The truly intravascular contrast agent, however, will demonstrate vascularity, and this can be used when there is a suspicion of torsion. There is, however, a whole body of thought which suggests that if there is a suspicion of torsion, no imaging is necessary, an operation should be performed. There is actually at the moment no data available to tell you how to use contrast-enhanced ultrasound in spermatic cord torsion. A small series of patients with torsion were examined, and contrast-enhanced ultrasound confirmed the complete absence of vascularization, but this didn't add any clinical information to the unenhanced color Doppler ultrasound examination. So at the moment, there is no clear role for the use of contrast-enhanced ultrasound in testicular torsion. However, if you have a problem such as this demonstrated here, where you have very severe epididymal orchitis, which results in global infarction of the testes, you can use your contrast-enhanced ultrasound to demonstrate the complete absence of vascularity in that testes, and this will influence the operative management. These patients have complete infarction of the testes. The surgeons will remove this testes to alleviate pain, and you are able to give this information to the surgeons that there is absence of vascularity to allow this procedure to be performed with confidence. Increased enhancement in the epididymis is clearly demonstrated, and on this view you can see two small abscesses forming in the epididymis. There is absolutely no vascularization of the testes, there is no blood supply to that testes will not survive. Orchidectomy is the correct management. Let's look at another problem with the testes, segmental infarction. This has a very variable appearance on conventional B-mode and color Doppler ultrasound. The benign nature of the lesion is established by its shape with markedly diminished or absent color Doppler flow. Traditionally, these segments of infarction have been described as wedge-shaped. However, not all segmental infarctions are wedge-shaped. Some may be round and may appear exactly like a poorly vascularized rounded tumor. With contrast-enhanced ultrasound, the subacute segmental infarction characteristically exhibits a perilesional rim of enhancement which diminishes over time and is eventually lost with changes in the lesion shape and shrinkage. Following these lesions up with contrast-enhanced ultrasound will allow the physician to document this change and be confident that the lesion is benign. This is an example of a segmental testicular infarct which looks very much like a tumor. However, there is no color Doppler flow to that area, and there is confidence that this is unlikely to be a tumor. Adding contrast at this stage allows the physician to clearly identify an area of infarction and to manage this patient conservatively. This is an example on the B-mode ultrasound of a very abnormal looking rounded area in the mid aspect of the testes, which following contrast enhanced ultrasound demonstrates no enhancement at all. There is no vascularity in this region. It is very likely to be areas of infarction and not tumor, and close follow-up will allow this diagnosis to be confirmed. The absence of vascularity following the administration of contrast is very striking. You should be able to see a single bubble traversing a blood vessel in the testes, not because that bubble is so big, but the reflection of ultrasound allows that bubble to be tracked. If the bubble moves across the field of view, that area is vascularized. The microbubbles are truly intravascular and do not leak. This is a very important point to understand. This is not like contrast-enhanced CT. It clearly shows an area of vascularity. This is an important paper published by our group to demonstrate that these appearances are seen in many patients with segmental infarction, and you can follow this pattern over a period of time with regression. There is enhancement in the periphery of the lesion. There's sometimes enhancement of remaining areas of vascularity within the lesion, but follow-up will always show regression. Let's move on to another not uncommon problem in the young, fit, athletic male patient: trauma. Conventional B-mode and color Doppler assessment of the testes in trauma is well established, but this often underestimates the extent of injury. If the injury is large and there is no chance of saving the testes, it is far better to remove the testes early on. The ultrasound examination, besides looking for the integrity or interruption of the surrounding tunica of the testes, also demonstrates for the surgeon the extent of viable testicular tissue. If this is large, testicular sparing surgery may be performed. A color Doppler ultrasound assessment does not always clearly demonstrate the fracture lines, the intratesticular hematoma, and the amount of viable testes. This is where contrast-enhanced ultrasound will add a great deal to your examination. In this example of a patient with a fracture across the testes, with a surrounding hematocele, with color Doppler ultrasound not completely demonstrating the vascularity of the testes, the addition of contrast-enhanced ultrasound will demonstrate that there is no viability present in that testes except for a very small area at the upper pole. This testes will not survive. An operation early on in the period of management of this patient will benefit the patient. Look at this patient. This patient sustained an injury when hit by a very hard ball. On the B-mode ultrasound, there are areas of hematoma present within the upper aspect of the testes, but the color Doppler ultrasound does not clearly show where the area of demarcation of viable and unviable testicular tissue is. The addition of contrast-enhanced ultrasound shows the fracture line, shows the upper pole avascular testes, and this is the non-viable testes. There was sufficient testes still being vascularized to allow the surgeon to remove the upper aspect of the testes and preserve the rest of the testes. Following operation, on the images on the right of this slide, contrast-enhanced ultrasound showed that there was viability in the entire remaining testes. This is a very useful application of contrast-enhanced ultrasound in the testes and should help surgeons delineate the surgical plane.